Thank you very much. It was interesting that the headlines yesterday were not about Brexit, were not about Hong Kong riots. It was about a new drug for Alzheimer's disease, aducanumab, which was a breakthrough. Well, we wait and see if it really is a breakthrough. The original results were not positive, but reanalysis suggests that maybe 25% of people may benefit. Does this mean this session is irrelevant now, that post-diagnostic support is not going to be so important if we have a magic bullet? Of course not. I need to be able to change the slides. Hang on. We heard yesterday from Helen, who's found that she has meaning in life, that her role as an advocate has really given her extra purpose. We heard about Peter, the forestry manager, who's doing excellently well and got good post-diagnostic support. But most people don't. Most people don't get post-diagnostic support, which is a human right. If I was diagnosed with diabetes, with stroke, with any chronic condition, I wouldn't just be given a diagnosis. Now, the process of diagnosis is still not great. It's not timely. There is still a lag of 2 or 3 years. And there are multiple reasons. The person living with dementia may be fearful, or their family may be fearful. It may be the stigma, or it may be the GPs who lack awareness, lack knowledge, lack time, lack skills, or being beneficent, being kind to the patient, and is fearful of the effect on the patient or the family. Now, post-diagnostic support is not about what you do to make a diagnosis. And as we've heard just now, there's a range of technology which is improving that ability. Post-diagnostic support is what happens next, because there's lots of guidelines on how to make a diagnosis. Most countries, developed countries, have these. The UK, the USA, the National Institute on Aging, Canada, Australia, Germany, and on and on and on. And nearly all these guidelines cover what to do. You take a history. You take a history from the person with the memory problems or cognitive difficulties, from their family member or someone who lives with them, knows them well. You look at the differential diagnosis for other medical conditions and psychiatric conditions which can masquerade as dementia. You do cognitive testing, I'm talking from the doctor's side of the desk now, and physical examination and investigations, and perhaps if you do diagnose a dementia of Alzheimer's, you might prescribe certain medications. The better guidelines will also discuss legal issues such as power of attorney, guardianship, work, and whatever they're called in your jurisdiction, work, driving, and financial management. But what they don't all discuss, in fact, few do, is how do you do this? What's the process? Do you see the patient, as a doctor I'm talking about patients, and family together or separately? I like to see people separately, if they agree. How to break the news, how to tell the truth or not to tell the truth, using the D, dementia word, or A, Alzheimer word. Should they tell everyone else about their diagnosis? Should they keep it a secret? Do we discuss management and prognosis? And I keep learning from the patients, because I work in a memory clinic and I've been seeing patients and diagnosing them with dementias for over 35 years. I learn from them, and I remember one patient who said she was very angry with me. It was her daughter, actually, because I'd done all the right things, I thought, but she walked away confused. She was overwhelmed and bamboozled by the information. Why hadn't I given her a written summary? She was absolutely right. And in fact, we now do that as a routine practice, and that daughter came and worked with me for 15 years in administration. So, guidelines don't tell you how to avoid what Kate Swaffer, who's here in the audience, called prescribed disengagement. When she was diagnosed and told to get her affairs in order, stop driving, and talked about family embarrassment and stigma and withdrawing from society. That's not what should happen. We should have a different aspect. How to help people living with dementia and their care partners. How to deal with the news, how to live positively with dementia, like Helen and Peter. A rehabilitation model or reablement. In other words, how to compensate for the handicaps so that the disability can be arrested, at least for a time, or even improved with appropriate intervention. That's our aim. And different professionals have a role. So if we talk about managing the medication, the physical comorbidity, such as high blood pressure or diabetes or whatever, it's often the role of the GP, the primary care practitioner. If it's the ordinary stuff of life, keeping things going, activities, at home, at work, driving, the occupational therapist has a key role. Supporting mobility and physical function, the physiotherapist and the occupational therapist have roles. Supporting cognition, communication, remaining connected. That psychologist, the speech therapist, particularly with some of the frontotemporal dementias or the Alzheimer's disease that, with the aphasia. Perhaps most importantly is how to support the person living with dementia emotionally. It would be great if we could develop a peer or buddy system from somebody who has been diagnosed. I'll come back to that. Psychologist, social worker may have a role here. Supporting the person cognitively and supporting the primary care partner. Because as we know, dementia is not just one person's illness. There's always, quote, a second patient or another person. I've been very impressed with the peer support program with breast cancer. A woman diagnosed or recently operated with breast cancer will be contacted by another woman who's been through the same process. And this has been quite a successful program, given a real boost in Australia when one of the cricketing stars' wives died young with breast cancer. There's also virtual peer support, such as Dementia Alliance International, spearheaded by Kate. In some jurisdictions, there's a dementia navigator or key worker. In Australia, we have such a program for young people with dementia, but not rolled out for everybody. We did some costing on this, and we showed this could be cost-saving if we could organise such a program nationally. We couldn't convince government otherwise. There are programs led by occupational therapists, like the TAP or COPE program from Laura Gitlin, improving function and engagement for people living with dementia. And there are day centres, not very attractive concept for people diagnosed. I'm really focusing mainly on early post-diagnostic support. But the Alzheimer cafes with Rosemary Droas has spearheaded here in the Netherlands and has now spread in many countries, or the PALS program is a day centre for professionals who are often reluctant to go to mainstream nursing homes. And of course, Alzheimer Europe and the various national organisations to support family carers and people living with dementia, now present in over 100 countries and brought together under the federated model of Alzheimer's Disease International. In Australia, a group at the Hammond Care did a review and looked at reablement. And it was a consultation process between the project team, people living with dementia, their care partners, health professionals, and literature. And they found there were three main themes that were important for post-diagnostic care. Supporting everyday living activities through an OT program, exercise and cognitive programs. Number 2, supporting mobility and physical function through falls prevention and exercise programs, and supporting cognition and communication, again through exercise, cognition and communication programs. There have been many interventions for people living with dementia, and I demonstrate them in this slide here. But let me just define some of the terms. Reminiscence therapy is discussion of past activities, events and experiences, aided by memory triggers. Cognitive stimulation is engagement in a range of activities and discussions aimed at general enhancement of cognitive and social function. Cognitive training is more of a guided practice in a set of tasks. And cognitive rehabilitation is where individual goals are identified and addressed. In summary, all of these interventions have shown some benefit, sometimes small, sometimes short-term, in things like quality of life, cognition, communication, mood, and function. Physical training, I think it was 67 out of 68 studies in the review I read, showed benefit on physical function. And about half the interventions showed benefit on cognition as well. Cognitive training, such as computer brain training exercises, have benefits for healthy older people and people with mild cognitive impairment, but there's very limited evidence for people once they have developed clinical dementia. Combining many of these interventions may be better. Really, the evidence is slim at this stage. I just focus on some of the work we did in carer support. Over 30 years ago, we ran a carer training program over 10 days for people with dementia and their carer for a 10-day program, and we showed reduction in caregiver stress or psychological morbidity, and what the graph is showing is the survival curve for staying at home. And there was a 5-fold greater chance of staying at home when the carers went through the training program compared to when they didn't. And there was cost saving. Now, the reason I'm telling you this is this year we published, or last year we published another study where we truncated that program into 5 days. And we combined it with respite care where the person with dementia comes into respite for a few days or weeks while the carer gets some respite. We said, why don't we bring them both in for 5 days? This was led by Meredith Gresham, and run a shorter training program, and we showed we could reduce caregivers' unmet needs, behavioural symptoms, and decrease nursing home admission against the comparison group. It wasn't a control study. This is another study that we did in conjunction with Alistair Burns in Manchester and Mary Mittleman in New York. And there was just 5 sessions of counselling for the family carer and family in the first 3 months. And what you see here is divergence in the carer depression scores over 2 years. In other words, an intervention of 5 sessions within 3 months, 2 years later, was showing a divergence in their results. There are many, many other interventions. It can be the environment too. And this is more for later stage dementia. In the Netherlands, of course, the De Hogewijk village has been a world leader and has been emulated in other places. In the US, the Eden Alternative and Green Care Farms. These are very attractive, and intuitively seem positive ways to go. However, the actual empirical evidence of their benefit is very small. So what I've done is I've talked about a menu of post-diagnostic support options for people living with dementia and for their care partners. It's not one size for everybody. It depends on the person, what they want, what their care partner wants, on the context, more importantly, what's available, and if they get the referrals. On the stage of dementia, there are many variables. The evidence for their efficacy is limited because research is difficult. It's expensive and hard to do. The question we've asked ourselves is, how can we package this program that best suits the person, their care partner, and that context? So we were fortunate to receive a grant organised through Alzheimer, through the EU, through the JPND. It's a brilliant program. They award these grants and don't give a penny. The money comes from the national organisations. I think it's so clever. Anyway, we got one of these grants, and the countries organised in here are Australia, Canada, Poland, Netherlands, and UK. And we're meeting here after this conference to co-design with people living with dementia, their care partners, primary care practitioners, and specialists in their area, a post-diagnostic support package. We're building on the work of PRIDEM, which has been led by Newcastle University. And you'll see on the bottom left the logos of many of the partners in that project. And it builds on the World Alzheimer Report in 2016 from ADI, which says we have to move to post-diagnostic dementia care towards in primary and community-based care. In their review of 23 papers, of 10 studies and 9 interventions, they found that a primary care provider case management partnership model offered the most promise. So this is how we're going to work. Almost finished. We have 5 work packages. Work package 1 is to design surveys and focus groups with those people I've mentioned, people living with dementia, care partners, healthcare practitioners, particularly GPs. The Netherlands is leading this. Work package 2, UK is leading, co-designing post-diagnostic support, building on PRIDEM. In Australia, we're working on implementing a marketing campaign, both for people with dementia and for healthcare practitioners. And we'll ask, these are people who've been diagnosed in the last 12 months we'll be interviewing at the beginning to find out what the current situation is and their satisfaction. We'll run the campaign, and then 12 months later, we'll recruit a new samples of people who've been diagnosed in that 12 months to see if things have changed. That'll be evaluated by Canada, and eventually we'll have a package, which could be a playbook, that's implementable in any country and adaptable by them to their circumstances. And Poland is leading that. So thank you very much. I'd just like to acknowledge the huge number of people in our team. It's just a wonderful team to work with. And I'm looking forward to our meeting on Friday afternoon and Saturday. And thank you very much for your attention.